Cardiovascular physiology. What I hope to do in this talk is take a few lesions and talk about the pathophysiology that occurs in the fetal life and how these issues can explain some of the findings that we see postnatally in our patients and the discrepancy between one patient and another. To start with, okay, it's a bit slow, but all right. To start with, I just want to go over some basic issues that I'm going to be using in my slides to explain them. So this is the typical heart diagram that was used by earlier researchers in this field, such as Dr. Rudolph, where the heart is sort of upside down, but this is the best way to explain it. So here we have blood coming back from the inferior vena cava, from the ductus venosus coming back from the placenta. This is the superior vena cava going into the right atrium, the pain foramen valley, obviously the ventricular chambers, and here the lung circulation, the pulmonary circulation, and the systemic circulation. The numbers that you see over here that are clear versus those that are in blue, those reflect cardiac output, and these are oxygen saturations. So in a fetal circulation, we talk about combined cardiac output. So the combined cardiac output or ventricular output, it should be in a born child 50 to 50, but in fetus, the right ventricle pumps out a little bit more than the left ventricle. In the lamb, where the research started, this is 60-40, but in human beings, it's felt that the right ventricle pumps 55% of the combined ventricular output, while the left ventricle a little bit less, 45%. As you can see here, 40% crosses the ductus arteriosus, where there's right to left shunting to go to the descending aorta, and out of this 45%, some goes to the coronary arteries, and then 35% to the head and neck, and only 10% crosses the isthmus, and that's why the isthmus is the smallest part of the aortic arch. 7.5% goes to each lungs, combined 15%. The 30% of the combined ventricular output or the combined cardiac output goes to the placenta, and 30% comes back. This 30% is not the same as this 30%. Most of this is oxygenated blood, but it's also contaminated with some deoxygenated blood. As you see here, that the blood that comes back from the placenta is 85% saturated, but only 70% in the lungs, because some of this blood will go to the right ventricle, and also some of the blood that comes from the inferior vena cava will contaminate this flow and lower the saturation to 70%. As you see over here, the oxygen saturation that goes out to the pulmonary circulation is a bit less than the one that goes out to the head and neck. So the head and neck and brain, etc., still gets a little bit higher oxygen saturation than the lungs, than the descending aorta and the pulmonary circulation. And the opposite is true, where the pulmonary circulation gets less blood than the brain. And this is important in what we're going to describe today. Important issues happen postnatally is that the cardiac output is significantly increased postnatally. So the oxygen consumption in utero is about 6 to 8 milliliters per kg per minute, while postnatally is quite a bit higher, 2 to 3 times higher. And this is provided by the change in the postnatal cardiac output. So prenatally, the right ventricle puts out about 250 ml per kg per minute from the RV, and a little bit less, 200 from the LV. Postnatally, it's 400 from the RV and 400 from the LV, so almost doubling of the cardiac output. I somehow changed the format here, but I think I can figure it out. All right. So what happens is that once the lung expands, the airway cleared, the oxygen content of the blood is increased, and this is a potent pulmonary vasodilator, so you drop your pulmonary vascular resistance. The cardiac output, we said, increases postnatally, and this is driven by mostly reduction in intrathoracic pressure because the child is breathing right now and the intrathoracic pressure is negative for the first time. This will enhance significantly the venous return and increase the preload, and as such increasing the cardiac output. The increase in cardiac output is assisted by these three factors: decrease in atmospheric pressure, and which increases the metabolic needs of the child, increase in the T3 level by 3 to 4 times, and in cortisol level. You have to think of the baby as being in a sort of a warm hibernation, if you will. It's an incubator with very little metabolic needs. Once the baby is born, the metabolic needs is significantly increased, and so is the cardiac output to match it. So as I said earlier, this is a bit repetitious, this slide, is that there is a significant drop in the pulmonary vascular resistance, 8 folds, and this is driven by the mechanical expansion as well as the vasodilation that increases the oxygen content and liberates the prostaglandin in the expanded lungs, which, as you know, are all vasodilators. From this point on, I'm going to start talking about congenital heart diseases. I'm sure many of you wondered about this before. We know that genetic abnormalities, be it chromosomal or genetic deletions or any other type of a genetic abnormality, as well as environmental factors, toxin, drugs, many things that we may or may not know, could cause congenital heart diseases. But I want you to consider the following factor. I want you to consider 2 pairs of twins that I follow. One of them, one pair of twins, one child has the most hideous congenital heart disease, multiple problems. It's basically a double outlet right ventricle with multiple other problems. The identical twin is perfectly normal. Another set of twins, one has double outlet right ventricle, and the other one, AV canal and tetralogy of Fallot. Sort of maybe partly similar lesions, but those 2 are also identical twins. There must be factors that we do not know at this stage why this happens. If you think of a huge genetic aberration, such as trisomy 21 or any of the trisomies. So let's take trisomy 21. A huge change in the genetic buildup of that child is there. 40% of these children have congenital heart diseases, and half of the 40% have AV canal defect. So 20% of children with Down syndrome with this significant change in genetic makeup have a consistent lesion, 20%. You say, this is significant. What about the other 80%? Why are they different? Why are they normal? Or did they develop a different congenital heart disease? So there must be factors that we cannot appreciate. Some of it might be hemodynamic. The way the hemodynamics changes because of the genetic abnormality may or may not lead to congenital heart disease and may lead to various congenital heart disease. And I'll try to touch on this in some of the lesions I'm going to talk about today. So let's start with something that we may consider simple as an atrial septal defect. So in ASD, the mechanism could be change in the flow between the IVC and the SVC. So if there is more flow through the developing foramen ovale from the inferior vena cava, be it from the ductus venosus or the inferior vena cava, it might be a driving force to this defect to be to remain larger and more patent throughout the development of the fetus. So there might be some hemodynamic changes that actually lead to the atrial septal defect. And as a consequence of the atrial septal defect, there are going to be changes in the circulation that I will elaborate, hopefully a little bit more clear than what I have over here, but let me just quickly go through it. Larger than normal flow across the PFO will cause larger left atrial flow and less right atrial flow. And this will cause more flow in the left ventricle and less flow in the right ventricle. So the opposite to what happens postnatally. And this is going to also alter the oxygen saturation to what goes to the brain and what goes to the lungs. And this could have consequences later on, as I will demonstrate in the next couple of slides. So over here, this is the more typical diagram of what we see, the superior vena cava, inferior vena cava over here, and the ductus venosus over here, and those dots show oxygen saturation. So in the normal, if you can look at this smaller diagram over here, most of the blood from the ductus venosus will go to the left atrium, and that's why the left side of the heart has higher oxygen saturation. However, some of this pink blood or well-oxygenated blood will go to the right ventricle, and also some of the blue blood coming from the inferior vena cava will cross over here. What happens in ASDs that cause the foramen ovale region, and I'm using it loosely, so I'm referring to secundum ASDs and primum ASDs, will encourage more of the normal thing, meaning it will encourage more of the ductus venosus to flow in here, less of the inferior vena cava, and perhaps no well-oxygenated blood to go to the right ventricle. And what this is going to cause is going to cause less oxygen saturation to go to the lungs, and this will cause vasoconstriction of pulmonary vasculatures, and potentially those patients may have less pulmonary blood flow postnatally because the vasculature of the pulmonary arterioles are well developed. On the other hand, if we are to examine patients with a sinus venosus type ASD, this will encourage flow of deoxygenated blood from the superior vena cava to the left atrium. Whenever you send more blood to the left atrium, that source of blood will be less to the right ventricle and to the pulmonary arteries. So in this situation, in this scenario, you could have higher oxygen delivered to the right ventricle, consequently to the pulmonary arteries and to the pulmonary arterioles, resulting in poorly development of pulmonary arteriolar vasculature in the lungs, and you end up having higher pulmonary blood flow postnatally. A lot of times you would wonder if, when I have an ASD, why, although the ASDs look exactly the same size, one patient presents in failure and the other one doesn't, one patient has more QPQS than the other. These are the factors that might interfere, that in utero life, there were already changes happening in your pulmonary vasculature or in the, if you examine other things like in the brain. Dr. Spray mentioned in his talk earlier this morning about the neurodevelopmental aspect of these issues, which is a very important issue that's being examined right now because those patients are growing up and we're finding out that at least that they have some attention deficit disorder, and at most they are neurologically quite devastated. And these changes could be actually happening in utero by something as simple as change in the oxygen saturation, which results in change in the oxygen saturation content going to one part of the body or not, and as such changing the direction and amount of blood flow to that structure. In aortic stenosis, and I'm going to use both aortic stenosis and hypoplastic left heart here, sometime together and sometimes separately, as there is a lot of overlap. This is sort of the issues mentioned here is a no-brainer, is that if you increase the resistance to the left ventricle, there will be higher pressure here, resulting in higher pressure here, resulting in less blood flow here. So this will feed into itself because now the less blood flow will cause poor development here and a smaller left ventricular chamber. Also, the fetus is different than the born child or adult in that if there is high pressure, instead of thickening of the myocytes, hypertrophy, you will have hyperplasia. What happens with hyperplasia is that the coronary arteries do not increase in their blood supply. They do not increase concentration. So you end up having more muscle cells to the same coronary artery tree and resulting in ischemia. And this obstruction causing less blood flow here will force more oxygenated blood to go here, which will go away from the brain. So in aortic stenosis, you could have the discrepancy that might result to some neurological problems, we think. All right, so here, hopefully this puts it in a little bit more clear fashion. You have left ventricular outflow obstruction, be it aortic stenosis in this case. You end up with high pressure in the left ventricle, which will cause high systolic pressure, which will cause LV hyperplasia, and this will cause decrease in the left ventricular cavity. Also, the diastolic pressure will go up, and as the diastolic pressure will go up, there will be decrease in the left ventricular inflow. This will cause reduction in LV cavity, and the reduction in LV cavity will lead to reduction in LV flow. So the bottom line, you have reduction in left ventricular inflow by these various factors, and this will decrease the right to left flow at the patent foramen ovale. The left ventricular hyperplasia we talked about earlier will cause reduction in the coronary artery density relative to the increase in the myocytes number, will lead to left ventricular ischemia, will lead to EFE as seen in many of these patients. The normal, and here I'm combining both aortic stenosis and hypoplastic left heart. If we see in normal, the RV-LV flow, as we said, is 55 to 45%, while in AS and hypoplast, you're going to have, and these are made-up numbers, they could be anything, but just to represent what I'm talking about, 70% from the RV, as I have in this example, and as such, only 30% from the LV. The high blood flow in the RV will cause increased flow in the main pulmonary artery, and this will cause increased blood flow into the PDA that will eventually cause the small aortic isthmus, which also caused by decreased flow in the aorta and decrease in the ascending aorta, and decreased flow will lead to the flow there. I don't know why I had it there in double. All right. Postnatal changes are important to consider. These are all a reflection of what happened in utero, because in fetal life, the placenta is highly vascular with low systemic vascular resistance and low ventricular afterload. So at delivery, what happens is that the placental circulation ceases to exist. Immediately, there's a significant increase in the systemic vascular resistance, and there is an immediate increase in the left ventricular afterload, causing to left ventricular strain. The left ventricular strain is compounded by the left ventricular hyperplasia and the coronary artery density that is low, and all these will lead to LV ischemia and EFE progression postnatally. Moving on to a different lesion. In tetralogy of Fallot, there is right ventricular outflow obstruction, and there will be right to left shunting at the VSD, which is not present in normal, obviously, and this will cause increased blood flow in the ascending aorta, and this explains why the ascending aorta is so large in these patients when they're born, and will cause reduction of flow in the MPA. The flow in the PDA will be reduced, and this it will be left to right shunting rather than right to left shunting, and these changes might be caused or enhanced by the change in the angle between the PDA and the descending aorta, here being more acute in tetralogy and here being more obtuse. And this might result, these factors, as well as these, in the fact that the PDA is long, small, and tortuous in patients with tetralogy of Fallot. This is the last lesion that I will review with you today as representatives of what the fetal changes pathophysiology could lead postnatally is Ebstein's malformation. So most cases are mild and you don't really see any significant changes. So we're talking more about those with a severe TR. So when you have severe TR, you're going to have an elevated right atrial pressure, and this will cause congestion of the superior and inferior vena cava that would lead to high drops, and I'll elaborate on that on my next slide. But there are significant changes because of this severe right ventricular abnormality or tricuspid valve abnormality. All right. So here, as I said, most cases are mild to moderate, and they will not have these changes. This only reflects the severe. So we'll start with the severe TR. This will cause right atrial dilation, which will increase the pressure in the right atrial pressure, and will cause hypoplastic lungs as the right atrial expands. A restricted PFO that accompanies this would lead into a much worse hypoplastic lungs. And that's why those patients that have hypoplastic lungs in the Ebstein malformation tend to have a small foramen ovale. The elevated RA pressure will also cause increased IVC pressure that causes congestion of the umbilical veins and consequently the placenta. So you'll have placental edema. And this will lead to high drops. The severe TR that we talked about over here also causes right ventricular dilation, and this will compress the left ventricular outflow tract. If you compress the left ventricular outflow tract in a patient that already has a compromised output from the right ventricle, then you have biventricular outflow tract obstruction, the worst case scenario you can have in utero, leading to poor cardiac output, decreased placental flow, decreased oxygen contents, and this will worsen the high drops. Severe TR also will increase the right to left shunting of the patent foramen ovale, further reducing right ventricular output and causing potentially functional pulmonary atresia. That might actually end up in morphological pulmonary atresia. The importance of understanding fetal physiology and fetal pathophysiology, I think, is going to make the change in how we understand congenital heart disease and its management. Right now, the earliest fetal echocardiograms we do is about 19 weeks, and even then it's really a challenge even with the best equipment. I truly believe as we get to see the heart at earlier and earlier stages, there will be a day where we can see the cardiac development as it's happening normally and abnormally. I don't know if you can appreciate this, but the heart, there is no heart in an embryo at 20 days of life. At 50 days of life, in 30 days or less, the heart has completed its development. So most women, even before they know that they're pregnant, the heart has completed its development. But I think with the advance of imaging to earlier stages, it will give us a tremendous understanding of not just the anatomical changes that are occurring that are potentially driven by genetic factors or environmental factors. We will see the altered hemodynamics as they happen. In my earlier part of my career, my research was in chick embryos and looking at embryos with cranial neural crest ablation. The beautiful thing about the chick embryo research is that you create a window in the egg, the embryo is translucent, and you actually see the heart pumping. You don't need an angiogram, you don't need a dye, and so you can see the normal and abnormal development as it happens. Once that happens in human beings because of our ability to see this, management of congenital heart disease will not be by surgery, will not be by interventional cardiology. It will be by our ability to alter the hemodynamic changes in utero before it's born. It's not going to happen in my lifetime, maybe not even my children's lifetime, but this will be the way for the future. Thank you very much.